Can we also talk about the misconception around if I take a painkiller, I will be addicted?
The first thing I would say is the pain you have is real. We know what is causing this pain.
So I'll give an example, right? When I'm a patient, I walk in, I only see kind of what I'm going through. I don't necessarily see behind the curtain or behind the veil in terms of like what are the many, many moving parts. So can you just give us a tiny peek into what a oncology nursing workflow looks like? Welcome to The Patient from Hell, the show where we discuss real stories, expert insights, and build a community that every cancer patient deserves. I'm your host, Samira Dasani, a bioengineer, entrepreneur, and a cancer survivor. Today, we're diving into the world of oncology nursing with Joshua Carter, a breast oncology nurse navigator at Stanford Healthcare. We explore the differences between palliative care and hospice care. We unravel the complexities of pain management, and we discuss the pivotal role that nurses play in patient advocacy. A few days later, I'm still reflecting on one of the key takeaways from Josh. The fact that there are over 30 steps for a nurse to take between when a patient has gotten an abnormal mammogram and when that patient is scheduled to see an oncologist. To listen to that and more, let's get started. I have, I think, our very first oncology nurse as a guest on the podcast. Hi, Josh.
Hi, Samira.
I would love to start by listening to how you ended up in oncology and how you ended up in nursing.
So when I was 8 years old, my younger brother was diagnosed with retinoblastoma. This was a time in my life I didn't really understand. We actually drove from Cincinnati to Philadelphia to the Wills Eye Institute to get radiation to his eye. And that's just where my mom said our primary care doctor sent us to go.
Wow.
That was an experience I reflect back on, and I think it was really difficult on my brother and my family, and just packing up, driving, staying in a hotel, coming back, and then the second story that with oncology in my family that was very was a part that inspired my work in oncology now was my grandfather in high school. He was diagnosed with lung cancer. I remember it was during the summer. He was in an ICU. I went in and again I didn't understand what was happening. And quickly I was told he had cancer, went on chemotherapy, which then turned into he became too sick. And then all of a sudden, my grandmother told us we're gonna bring a bed into the home and he's gonna go on hospice. So this was all very quick within a matter of months. So this really changed, I think, how I saw like my future career when I was entering college the next year. So I've always wanted to go into some sort of medicine, healthcare. I didn't really think I was going to go into nursing though. I thought I was going to do more sports medicine. My focus was really on working with athletes or versus physical therapy. But I think this kind of did have some change in my direction. And then what kind of solidified my inspiration with oncology, I would say, is my last practicum in nursing school. I chose to work on a solid tumor oncology unit in Cleveland. And this really opened my eyes to the oncology patient and the caregiver and how important the nurse is to the team. So I think that was an experience, those 200 plus hours of really seeing what the patient and family goes through. I think I was very fortunate to work at this hospital because they had a palliative care unit, they had a solid tumor unit, a leukemia unit, bone marrow transplant. So I did get to experience a lot of what an oncology patient may go through. And I really did see that the team that I would have an opportunity to work with is something that I was really inspired to go in that direction.
Thank you for sharing that. I'm sorry you've had to go through what you've gone through. That seems like a lot for a young, very, very young kid. And then I think in sort of very transformative years of being a teenager too. So I can absolutely appreciate how it shaped your life and career. Josh, there were two things you said. Can you help us define or differentiate between palliative care and hospice care?
So I think the best way to think of it is I think many times they focus to achieve the same thing. So you could think of hospice as specifically designed for patients who have a prognosis of less than 6 months of life, as given by their physician. Palliative care will focus on the same things as hospice, as improving quality of life, providing comfort to the patient, providing dignity to the patient. And I think um, palliative care can be given at any time during a serious illness diagnosis. At the start, it can be given through any time of that illness, whereas hospice is defined in the last 6 months of life.
I never really understood why we get confused between the two, but I think the way you just defined it, I think I finally understand. Because it sounds like the intent is the same, i.e., improve quality of life. And the real difference is when it's happening between someone who's in the, say, curative setting or has much longer time horizon in front of them, and the other one is really sort of focused on that end of life period. Is that right?
Correct. Yeah, I think they both really approach the same symptom, comfort, holistic support for patient and families, but it's really dependent on that the time point. Yeah.
Can you also talk, Josh, a little bit about who in the clinical team is managing palliative care versus hospice care?
They're both multidisciplinary teams. You would, of course, have a physician, a nurse, social workers, chaplains, volunteers. I think you would have other administrative team members that work with them. I think pharmacists provide an integral role as well for medication management. And also, when I think of hospice and palliative care, sometimes patients may need medications different routes. So they may need a lollipop pain medication. They may need um, something that could be dissolved and given in liquid, right? So I think of a pharmacist, and working with the physician is very important. Just providing the correct route of the medication if they need a medication that could be dissolved under the tongue. So those are the main team members that I would think of.
And how do you see the role of nursing in all of that?
The role of the nurse, I think, in all of this is the advocate for the patient, in the sense of the primary person assessing the patient on a day-to-day basis, or the first person the patient calls. I would see the nurse as the kind of key to the multidisciplinary team, connecting that communication between the team members. I see the nurse as someone that can really be the first person to provide the education as well around different symptoms to expect and the medications that may be prescribed.
Awesome. Okay, super, super helpful. Can we maybe do a quick overview from you? I know you read the Corey sponsored study. I'd love to just get like an overview. What was the study about? What are the researchers? What were they trying to do? And then maybe a little bit about what they found.
So the PCORI study was looking at a e-health intervention to address barriers to pain management in hospice patients during end-of-life care. It did involve two separate hospices. I know during the study, one of the hospices were kind of acquired, or they said that they kind of um, grew into a larger practice. But what they were looking to achieve were tailored educational content to address fears about, I guess you would say, pain management, addiction concerns, tolerance, side effects, and they wanted to improve knowledge to hopefully achieve medication adherence, and of course the pain relief measure that was indicated. The patient and caregiver were both involved with the education modules with this intervention. The study was used a stepped wedge randomized controlled trial. And what this meant is that basically from the start of the study, everyone was on the control, which was a video game that they had within the tablet. And then at a step or a point in time, they selected a random group of patients that would all go on the experimental, the the tablet that would the pain relief it system.
Huh.
And so over time, eventually everyone would go on this intervention. The study did not meet their primary outcome of the pain management adherence, but they did find and they're not sure if it's statistically significant, but they did find that this reduced pain misconceptions among caregivers. So I think that intervention in itself, I found powerful as a nurse. I think in this setting, a subset of patients, I truly think the caregiver is one of the most important pieces. And if we can provide um, education around pain misconceptions, that's very important.
Josh, can we maybe take a tiny bit of a step back? Can you talk about pain management in cancer? What causes pain? Why are patients struggling with pain? And then maybe, especially in the end of life setting, why are we like why is pain management, like why are we talking about pain management? Like what is happening in the lives of these patients?
Yeah. So when I think about pain management, I first think about, do you always have this pain or does it come and go? You mentioned what may cause pain in cancer. So um, with cancer, it can spread to different areas of the body. So I think if it spreads to the bone, many times patients can have considerable bone pain. If pain is in a certain area that could be blocking, obstructing, just causing pain where the cancer is, it can cause serious pain to the patient. In regards to managing the pain, I think of, again, it goes back to, is this a constant pain or is this pain that comes and goes? So if it's a constant pain, then typically patients are on around the clock medication or extended release medications that so they always have something on board. And then usually they'll have breakthrough pain medication. So if they're walking and they do something that may flare the pain, they have additional medication that can help maybe buffer that time frame from the long acting pain medicine.
Josh, I think you said extended release and breakthrough. What does that mean?
Yeah, so extended release would be usually given for patients that have pain that is always there. So I think of someone that says, my pain is always, I rate my pain as being a 7 out of 10. It's in my left hip. It never goes away. It causes me discomfort. I can't sleep. I'm unable to really move around. I have to lay in one position. After the patient's given a extended release medication that may take time to come on to go into the system, but once it's taken effect, the patient may tell me, oh, my pain now is manageable. It's a 3 out of 10. I can sleep. I can walk. But sometimes if I want to go to the grocery store and I cause this hip to walk around quite a bit, now my pain's back to an 8 and I need to take something to get that down. So I know if I'm going to the grocery, I'm going to take this pill before I go to the grocery, and hopefully it will prevent that pain from happening. And when I say breakthrough, I mean kind of like those situations that may cause the pain to break through.
And you say breakthrough, it's like cause the pain to be more than normal, I guess.
Yeah, or if something either I did or something that happened to me, or my cancer could be progressing and it could be causing more pain, and now the doctor knows if I'm having breakthrough pain, I need to assess what may be causing the breakthrough pain. If it's not an everyday, like an activity, if I'm just sitting here and it's coming breaking through, then I would recommend that the physician or the provider assess the pain.
Got it. So can I just maybe summarize really quickly? So it sounds like pain is both a potential symptom of cancer, right? So cancer spread to my bones, I'm having pain, but it also sounds like it could be a side effect of treatment.
Yeah, I think that's hard to answer. I think it's dependent on the patient, of course. I think if you're I was speaking more in the sense of, if a patient has considerable pain in a certain area and they know if this type of exercise or this activity will cause a flare in the pain or maybe even positioning, um, then they may need to take the breakthrough pain. Like for example, I could tell you, like let's say a patient needs to go in for a scan and they know if they lay on their back for extended amount of time, their pain increases. They have a hard time laying in that position. So the patient kind of already knows that I need my breakthrough pain medicine and I'm going to take it before I even go in for the scan, because I know if I lay in this position, it will cause me more pain.
Interesting. Okay. And then I think there was something else you said earlier, and I think this is in the paper too, which is what are the pain misconceptions in caregivers? Like, what are some misconceptions around pain, just broadly speaking? And then maybe the
Mhm.
second part of that is, what are some misconceptions specifically for caregivers?
The first thing I think about is how does this medicine work? Will I get addicted to this? Is this something that I agree with? Is this something my family agrees with? I think of the family factors of if the patient is not necessarily able to report the pain in a certain manner, that the caregiver may not know how to assess the pain, or if the patient's sleeping and unable to verbalize the pain, it may not be able to assess the pain if the patient is sleeping, right? Um, I think in regards to the caregiver too, I think it's important to start earlier in the diagnosis, educating the pain, because if you wait till the very end, I think it's less likely to the education to come on board.
Interesting. And just so that we sort of like help our audience understand, uh, and correct me if I'm wrong, but communicating pain from a patient perspective is primarily self-reported, right? As an I, patient, need to tell someone I am dealing with pain, and quantification of that is on some scale, 0 to 10, 0 to 5, mild, moderate, severe, very severe, something of that sort.
Yeah, that's right. And I think that's what I was trying to say about the misconceptions is if the general way is I ask the patient, how are you feeling? There are different pain scales. So there are nonverbal pain scales. There's all different types of pain scales out there. Um, but I think if the caregiver does not understand those different ways to assess pain, and if they just rely on the patient to tell me, "Hey, are you in pain? Are you not?" Then it could have a lot of it could cause those misconceptions and fears about the pain management.
Interesting. Interesting. Okay, I think I understand that. And then can we also talk about the misconception around, if I take a painkiller, I will be addicted?
So that is something that you hear quite a bit when you talk with the patient. Well, so and so, I don't want to take this. I'm worried I'm gonna um, be addicted to this. I think the first thing I would say is the pain you have is real. We know what is causing this pain. We know this medication will help, will give you a benefit and relief. And this will also allow you to have a quality of life where kind of what we talked about, going to the grocery, walking around the house, going outside. So I think that that's really where I start is focusing on we know what's causing this, and this is if this cancer is not going away, we want to think of it as this is not something that it's a short term. This is a long term where we want to help you with the quality of life.
Josh, are all pain medications addictive?
It depends which class of pain medication. If it's a analgesic, if it's a certain class, they are considered addictive. If it's something over the counter, they're likely not addictive.
Hmm.
Um, yeah, it just depends which prescribing class the drug is in.
So is it fair to say that a patient who is dealing with pain has at least some option set in terms of how to manage pain?
Yes, there's a wide range, I would say, even from pain medications to medications that may be more used for neuropathic pain or pain that um, may be causing, yeah, like a neuropathic pain. It may not be a controlled substance, but it may be a medication that may be used for seizures, but we know it also works for neuropathic pain. So I think there are many different classes of medications. Just as you would think with nausea medications, there's many different classes of nausea medications that you get the same benefit. And many patients maybe want to start somewhere on the lower spectrum before going all the way to the strongest medication.
Got it. Got it. Okay, super helpful. Let's maybe talk a little bit more about the sort of e-health intervention and any sort of challenges the research team had faced. I'm sort of switching gears, less on the pain side, more on the kind of study side. If you were thinking about implementing a digital technology or something like that, what did the team encounter?
Yeah, the first thing I think the nurse struggled with adopting this into their workflow when I read it. I think it was very difficult um, to find where it fit. So it was a clinical decision support tool that when the patient put in their pain score, it would send a message or an email to the nurse and they would get a notification. And I think they would have to click on that notification to actually see what happened. And sometimes the nurses would say, I'm resistant to this. I'm already assessing the patient. Why do I need to read this email? And it's easier for me to just talk with the patient or see the patient and do it myself. So I think the first thing is like their whole resistance to changing their practice of how they do things. So with that aspect, I think with the clinical decision support tool, it would have probably been helpful to have the nurse involved with the study design more and understanding the current nurse workflow, and that would have maybe helped with them answering more of those messages.
Got it. And then can you talk about, you said clinical decision support tool. What does that mean?
So there are many tools that we use, I guess, in our electronic health record. Some may say if you have this score, you may be risk for infection, but it's really a tool that can provide us a intervention. I'm trying to think of the best way to phrase it, but it's really a way to trigger a decision or basically help guide the end user, which in this case is the nurse, into making a decision that we know works. So if a patient has a 7 out of 10 pain score and it triggers a message to them saying, I have a 7 out of 10 pain score, it's going to trigger, I need to give this medication to effectively manage the pain.
Interesting.
It can become very complicated when you look at the electronic health record, but that's a very simple is that we use these interventions to guide our workflows and in our practice.
Josh, can you help us define workflow? Because I'm not sure patients fully understand that behind the scenes. Because I'll give an example. Right, when I'm a patient, I walk in, I only see kind of what I'm going through. I don't necessarily see behind the curtain or behind the veil in terms of like what are the many many moving parts. So can you just give us like tiny peek into what a oncology nursing workflow looks like?
Would you want me to tell you kind of like an outpatient workflow or inpatient workflow?
Good question. Let's do outpatient. I should define outpatient too. I'm not sure everybody understands that. So,
Yeah. So an outpatient, I think of you're going into the clinic or a doctor's office or an oncology clinic. And this could be somewhere where you're following up with your physician. We could say your one I'm really familiar with right now is a workflow as an oncology nurse. I work with our breast imaging department. So a patient has I have an abnormal mammogram. My OBGYN tells me I need to get a biopsy. A patient calls into our clinic. This is kind of a whole workflow. A patient calls into the clinic. I have abnormal imaging. I need help getting a biopsy. The new patient coordinator on the phone now sends the message to me, hey, Josh, can you please help them get a biopsy? I then have to call the patient and tell them the next part of the workflow is I need your breast images reviewed here because I need to make sure our radiologist, who's the doctor that's looking at all of your images, really wants a biopsy. The next part of the workflow is that physician now makes a recommendation. Yes, you need a biopsy on your right breast. I call the patient, the doctor puts in the orders, let's do a biopsy of your right breast. You then go in to get your biopsy. We talk through that this may take multiple days to get your results. Call me when you have your results. And then the next part of the workflow is I then will call the patient. We have your results, or the patient will likely tell me I have my results. My doctor told me I have a new cancer diagnosis. I then have to work with the patient on scheduling with the appropriate physicians they need. And this is just one example of a workflow of explaining that to get from point one to all the way in the outpatient clinic to see that oncologist, it may take 30 steps. So this workflow is an example of how many steps there are from a patient from having abnormal imaging to coming into that first appointment.
I'm kind of stumped. I actually know I know at least 80% of the workflow, and oh my God. From the patient perspective, it's like I got an abnormal mammal. I need a biopsy. So it's like step one, step two. But between that, what you're describing is so complicated.
I think just the fact where you have to pull the images to your current system can be difficult because you're not only dealing with your current staff, you have to call and have someone else from another facility help you. So it's you're advocating for the patient at many steps and you're providing support where there could be many gaps in care that where the nurse tries to prevent those gaps, as you could see along those many steps.
Oh, sorry. I just listening to the workflow just gave me like I think I got goosebumps just listening to that. I think it's I do think I'm glad you used that example because I think it's very common. I think there's a lot of misconceptions, not the right word, but I guess not fully appreciating how complicated a nurse's or a patient intake coordinator or a clinician's life is in the patient community. I think that's hard. I don't think, at least I did not appreciate how complex it is. And I really am grateful you shared that example. Because hopefully it sheds a bit of light into from point A to point B, you're looking at 30 plus steps. So all right, going back to pain management. I'm watching the clock and I think we can start like closing out. I'm gonna ask you a bunch of like really quick tips and tricks. You've been working with patients for a very long time. So if you had to give a patient who is currently in treatment, not hospice, one tip around pain management, what would you tell them?
One tip is I would have palliative care involved from the very beginning. I think they're experts in managing pain, and I think they're the team that I would recommend there.
Awesome. Now, if I'm a patient who is in the last sort of 6 months and my clinician has had that conversation with me and I'm dealing with pain, what would you recommend?
Yeah, your hospice team is going to be your go-to team. The oncology nurse is going to be your advocate. So if your pain is not being managed, I would recommend getting in contact with the nurse, and this could come from the caregiver perspective as well. I would call the oncology hospice nurse.
If you could stump one misconception around pain management and debunk it, which one would it be?
Just because someone may not look like they're in pain doesn't mean they're not in extreme pain.
Wow. Oh, that's good. Sorry. That's a really good one. What is one tip you would give to a caregiver dealing with like a loved one going through treatment?
To make sure that you get rest yourself, I think caregivers put a lot of burden on their shoulders, and I think we sometimes forget to get our sleep at night.
And then lastly, Josh, if you could give one tip to your fellow oncology nurses, what would it be?
I think one thing I would recommend is to try to be somewhat disruptive where you work. I think sometimes it's easy for us to say, okay, I'll do this, but I think if we can push the needle to advocate for the patient and design things around the patient in the middle, I think that's really helped me along the way.
Josh, thank you so much for being a guest on this podcast. I have a feeling there's going to be a lot of patients and families who will benefit from this episode. So thank you so much.
You're welcome, Samira.
This episode was supported by an award from the Patient-Centered Outcomes Research Institute. This podcast, show notes, and newsletter is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or any materials linked from this blog is at the user's own risk. The opinions of the speakers are their own and do not represent the opinions of organizations they're affiliated with, nor do they reflect the opinions of Mantacares Inc. or Mantacares' sponsors.